Okay, we'll get started. The fire alarm was going off in my building, so I found a little classroom here at Mission Bay. Try to take advantage of the whiteboard, but I'm ready to get started. We are really excited to hear from Dr. Aarthi Sabanayagam this week, who is Assistant Professor of Medicine at UCSF and co-director of the Cardio-Obstetrics program and the Pregnancy and Cardiac Treatment, or PACT clinic. She completed her cardiology fellowship training at New York at Montefiore Medical Center and her congenital heart disease fellowship here at UCSF before joining the Columbus, Ohio Adult Congenital Heart Program at the Ohio State University and Nationwide Children's Hospital. She returned to faculty here at UCSF in 2020. Dr. Sabanayagam serves on the AHA subcommittee on adult congenital heart disease and is a member of the International Society of Adult Congenital Heart Disease and the Adult Congenital Heart Association. Her clinical interests include caring for the growing ACHD population, as well as focusing on cardiovascular diseases in pregnancy, which we'll hear more about today. So I'll turn it over to you, Dr. Sabanayagam. If anyone has any questions, please feel free to put them in the chat or raise your hand and we can have you ask your question in person.
Thank you, Dr. Naroji. That was a very kind introduction, and I'm excited to be here to present Grand Rounds. And so my talk today is titled Sliding Doors, and I really wanted to focus on the high-risk cardiovascular patient and pregnancy, as well as the PACT program. And the PACT program stands for Pregnancy and Cardiac Treatment Program. And we're excited to have that with us. So disclosures, none, I'm not an obstetrician. This is a clinically focused talk. And for the most part, it's an overview of PACT, the challenges we face with high-risk patients at our center. So I wanted to start off with a scenario. This is a 36-year-old lady with Epstein's anomaly and severe TR, who I met a couple of years ago. And after attempting IVF for many years and not being able to conceive, decided that she was going to adopt a child. And during her clinic visit, I basically reviewed her studies. She had severe TR, RV dysfunction, and I had planned on working her up for surgery with an MRI and a cardiopulmonary stress test. And since it was the first time I was meeting her, I said, why don't you get these studies done? And then I'll see you back in 6 months, and then we can go from there. While that's going on, she calls me a couple of months later saying that she is pregnant. So she is not going to go ahead with the adoption since she's pregnant. And then I went back and I was like, well, I'm actually was planning on sending her for surgery. The good thing is that she was asymptomatic. She had no symptoms on exertion. Her oxygen saturation was on 95%. And I went back and looked at her imaging. I didn't have up-to-date MRI information, but on echo, she had a severely dilated RV with mild RV dysfunction. This MRI was from several years ago. So how would you assess her risk for cardiovascular complications during pregnancy, especially since I was actually planning on sending her for surgery prior to this unexpected piece of information? So my objectives of my talk today is really to talk about the landscape of cardiovascular disease in pregnancy, the hemodynamic changes in pregnancy, risk scoring systems, and then the Pregnancy and Cardiac Treatment Program PACT workflow, the challenges that we face in management with these patients, and then finally, final thoughts. So this is a slide that I wanted to start off with. It basically shows CDC data, that pregnancy and birth rates, sort of like peaked in around 1990, and then since then have been steadily declining. The graph to the right shows that, for the most part, pregnancy is pursued primarily by those in their 20s and 30s. However, in recent decade, there has been this slight shift with women who are in their 30s and 40s pursuing pregnancy as well. And that's probably also because they're utilizing IVF. When you look at maternal mortality here in the US, this is a graph that shows that from the 1900s, pretty much mortality plummeted around the 1950s and really hit an all-time low in the 1980s. However, in recent decades, there's been this really concerning yet very slow rise that people are paying attention to. And what this has been attributed to is probably, the fact that there's a trend in the ages of the women pursuing pregnancy. There's probably increased comorbidities in the health of these patients. Of course, our broken healthcare system that really needs a lot to work on. And a huge part of this is also attributed to social determinants of health and structural racism. When you talk about like racial disparities in pregnancy, as I was saying, that there's this rise in mortality for all women. For white women, it's a lot less. And then for Black women, there's this dramatic rise that we are seeing, that there are a lot of efforts across the board in trying to understand that, figure that, research this, and implement changes so that we can improve outcomes across the board. When you look at the causes of pregnancy-related mortality, this is at 2 points, 20 years apart. There is an increase in conditions like cardiomyopathy, stroke, cardiovascular disease in recent years, as compared to predominantly hemorrhage and hypertensive disorders of pregnancy, which was more in the 1980s. And now there's this increase in cardiovascular complications that we are beginning to see. Switching gears a little bit, I also wanted to mention that as an ACHG physician taking care of these patients, what we do know is that now adults outnumber children with congenital heart disease. And this is dramatic looking from 2005 onwards. There's this huge rise, and this is from Arian Morelli's paper. And that includes also complex defects. Now that with improved techniques, improved surgical care, post-operative management and follow-up, these patients are living longer. And so there are many young complex defects, patients with complex defects that are surviving and now in their 20s and 30s, waiting to start a family, waiting to pursue pregnancy. And these patients are those that we need to follow as well, because there is an increase in cardiovascular complications in this subset, especially if they're complex. So to summarize, the rising mortality trends, more women in older age groups pursuing pregnancy, significant number of young patients with complex CHD surviving, as well as recent data showing that patients who develop adverse pregnancy outcomes, APOs, are at higher risk for cardiovascular disease in the future. That has enabled a more structured and rigorous appreciation for development of a formal cardio-obstetrics program. And the areas of intervention really are like, understanding the disease spectrum, understanding the social determinants of health, understanding the physiology and the impact that pregnancy has on the cardiovascular system, the need to develop a pregnancy heart team and a multidisciplinary approach in taking care of these patients, improving research and registry data, trying to understand pregnancy outcomes in patients with congenital heart disease and peripartum cardiomyopathy, as well as on healthy lifestyle interventions with these women with CVD. And also some really exciting research that's going on with large multi-center phenomic and proteomic investigations of APOs, as well as the role of placental ischemia in the etiology of these APOs. And then lastly, really improving training and education for our fellows and trying to incorporate COCATs, incorporate modules into the COCAT recommendations in fellowship. So when we talk about the hemodynamic considerations in pregnancy, what we're really seeing over here is, we all sort of like know this, and I'm just going to go through it a little bit more, but there's an increase in cardiac output, that plateaus off somewhere around the second, third trimester, and then drops immediately after delivery. Next comes heart rate, which for the most part goes up by about 10 to 20 points, but then there's this huge rise in heart rate around the third trimester to delivery, again, dropping off after delivery. Next is blood pressure. For the most part, the blood pressure drops by about 10%, but kind of like relatively remains probably stable throughout. And then last, and this is probably what drives the blood pressure and the cardiac output, is the fact that the systemic vascular resistance really plummets. And all these changes are important to understand when taking care of complex patients with abnormal physiologies and anatomies. Another thing to kind of like keep in mind, especially when when we talk about delivery, is at the time of delivery and what this plays with their underlying anatomy and physiology is like when patients undergo contractions, there's a pretty large amount of blood that gets released into the system. As well as with delivery, people always think that vaginal delivery, a C-section is actually better than vaginal delivery, and that's actually not so much the case. There is a lot more blood loss, which may impact the physiology of these patients postpartum. And then lastly, there's this autodiuresis that happens in the first 48 to 72 hours. And if that doesn't happen adequately, then patients, with heart failure can suffer during that brief period of time. And then lastly, baseline hemodynamics return takes probably about 6 weeks. We really wait 6 months before we make any kind of decisions long term, but it takes at least 2 to 6 weeks, probably longer post C-section, for a woman to return to probably not their pre-pregnancy baseline, but at least to their new baseline. This is a nice flow chart. And again, you don't have to look through each of these boxes, but Mary Canobio and UCLA came up with a nice sort of algorithm in terms of how do we manage patients with complex congenital heart disease. And this was a scientific statement that was prepared by the AHA. This approach is something that we have incorporated across the board, even with acquired heart disease as well. So in terms of looking at our PACT workflow, pregnancy counseling, assessment, sort of how do we from start to from the initial first visit with these patients to monitoring them during pregnancy as well as postpartum, how do we go about that in our PACT clinic? And we really start off with complete history and physical exam, obtaining any prior health or surgical records, especially for congenital patients. That is vital and very, very important. Obtaining baseline studies, ECG, echo, any rhythm monitoring, any labs that would help understand what their baseline physiologies are. Cardiopulmonary stress test is something that we do a lot, especially with our congenital patients, because we know that congenital patients do not have the same kind of exercise tolerance as someone who is their age, who has a normal heart. And we usually tell them that if you can fly through a cardiopulmonary stress test, then you probably will be okay during pregnancy. And that does help in terms of being able to risk stratify them based on functional status. If any kind of medical or surgical repair is indicated, then it's best to do that at the time of preconception, if indicated. And then genetic referrals, especially for those with heritable cardiac conditions. And you definitely want to be able to discuss any kind of drugs that they are on, medications, not drug, medications that they are on prior to conception. So those can be withdrawn beforehand. And until they decide that they want to get pregnant, be able to offer them appropriate contraception after pregnancy is desired. This always surprises me, when we talk about cardiac medications, there are a lot of people out there who, patients themselves, they are scared with the kind of medications that they're on, if that is safe or not safe during pregnancy. And so are many physicians and providers. And so it's kind of good to go over these lists with them and let them know if this is something that's contraindicated, then we would like to pull that out sooner if you're contemplating pregnancy. But for the most part, a lot of the heart failure medications are contraindicated, as well as the DOACs. Statins used to be contraindicated. Now that's a revised guideline, and it's probably safe. And in terms of the other medications, especially the antihypertensive medications, some of the antiarrhythmics, sildenafil, prostacyclins used for PH, heparin, coumadin, for the most part, are all safe, and beta blockers. I think sometimes a lot of times we see patients who have been taken off their beta blockers as soon as they're pregnant, and that, for the most part, while it is associated with preterm delivery and low birth weight babies, those are probably at higher dosages. At smaller dosages like 12.5 or 25, they're probably just safe with minimal risks. So in terms of surveillance during pregnancy, once the patient does visit the PACT clinic and actually sees both MFM and cardiology, we really want to be able to establish like a point of care for these patients, like who's going to manage them on a regular basis. Are they far away, remote, living in a remote place where they probably do have their local physicians and providers and then just need to see us, ever so often? Or are these people that we're going to ask to actually like probably move to the Bay Area so that they can be monitored here? And in some cases, we may actually even hospitalize them. And so that is something that we decide pretty early on if they're high-risk conditions. And then, of course, if anything changes clinically. For the most part, we get echoes every trimester. Sometimes I'll skip the first trimester, but we usually definitely get one around like the 18 to 20 weeks. And then again at 28 to 30 weeks when hemodynamic changes have peaked. And then fetal echocardiography, especially in congenital patients and those with any kind of like syndromes or genetic mutations, we would get that at 18 to 22 weeks. We outline sort of like, fetal, maternal and fetal morbidity and mortality risks, including the need for hospitalizations. And all this is really like, joint decision-making made by the patient, the family, the cardiologist, and the MFM team, as well as anesthesia in certain cases. And so in terms of follow-up, we use sort of like the modified, like, WHO kind of system that was incorporated into the ESC guidelines, where depending on like which category they fall into, we might see them once every trimester, once or twice during their pregnancy, or maybe even monthly. In terms of a delivery plan, for the most part, again, patients always have this misconception that if they have a C-section, it's probably safer, and that's actually not true. Vaginal delivery is the preferred approach. We do, however, consider assisted second stage, especially in cases like aortic stenosis, hypertrophic cardiomyopathy, Fontane's, and in very select cases, C-section may be required. For example, patients with aortopathy with very dilated aortas, or if they come in with decompensated heart failure and cardiogenic shock. In some cases of pulmonary arterial hypertension, and especially in those patients who are on Coumadin and have not been switched yet. And that is not so much for cardiac indication, but because the MFM docs usually do not want the fetus moving through the vaginal canal for fear of ventricular hemorrhage. So in terms of like planning for labor and delivery, we have multidisciplinary conferences every month. And pretty much during those conferences, we start like discussing them kind of like once they're well into their second trimesters. We don't discuss them as early on unless it's a high-risk case or it's a high-risk preconceptional case. For the most part, we wait until they're about 24 to 26 weeks before we start discussing them in terms of like how do we plan on following them, where do they need to be relocated, what is their approach for anesthesia in terms of early epidural, do they need endocarditis or not? For the most part, endocarditis prophylaxis is not indicated. What is the timing, mode of delivery, and whether they would need assisted second stage or not. And if postpartum, like where would they deliver? Would they deliver at L&D? Would they deliver in the ICU? Would they deliver in the OR? And then postpartum, like do they need ICU monitoring? And if they need ICU monitoring, what exactly is that for? Is that for telemetry only? Is it like, do we need hemodynamics with an A line and a CVP? We've moved away from using PA lines for the most part. The only time we ever need a PA line is when someone comes in with cardiogenic shock, but we can usually get away with just a CVP. So switching gears now to scoring systems. Kind of like with the tools that we have in hand, these are the 4 that we use, and I'll kind of like touch a little bit on each of these scoring systems. So CARPREG came out in 2001. ZAHARA, which was for congenital heart disease in 2010. And then you had the modified WHO as well as CARPREG-2 that came out in 2018. And the time interval between both CARPREGs, which is from the same institution in Canada, was almost like 20 years. And so when you're looking at like, the underlying condition, underlying pathophysiology, it's important to know like, well, what is the timing of complications in in these women. And for the most part, like you're really looking for arrhythmias and heart failure as well as death, but it's usually arrhythmias and heart failure. And arrhythmias tend to occur early on during pregnancy, with heart failure later on, kind of like towards the third trimester. And then postpartum is probably where we end up having a much heightened sense of awareness so that we can follow these patients. So CARPREG stands for cardiac disease in pregnancy. And this was the first risk index that was devised with a prospectively enrolled study in Canada, where they looked at 562 patients with 599 pregnancies, and 13% of those pregnancies were deemed to have cardiac complications. And those included pulmonary edema, arrhythmia, stroke, or cardiac death. And each of these factors were found to be independently predictive for cardiovascular complications. And so these predictors were incorporated into a risk score. And those factors were prior cardiac event or arrhythmia, NYHA functional status greater than 2 or cyanosis, left heart obstruction, or systemic ventricular dysfunction. And so when you look at these predictors here at the right-hand side of the screen, basically they said that, well, if everyone started off with a 5% estimated risk. So if you had 0 predictors, you were straight off the bat at 5%. And if you had 1, you were at 27%. And if you had greater than 1, then it jumped all the way up to 75%. And you can see how with just like one category, imagine if someone had an SVT, they were then being quoted a risk of 27%. And that probably seems a little too excessive. However, if they had LV dysfunction and poor functional status, then that was probably appropriate, so that you probably did capture those patients. But whether their estimated risk was 75%, well, that's something completely different. What we also noticed with CARPREG was that ZAHARA CARPREG did not capture patients with congenital heart disease. As you can see, none of those 4 predictors are factors that we can apply to patients with complex CHD, as they might not be, as they might be missed. And so ZAHARA really focused on patients with congenital heart disease, and they looked at 1,302 completed pregnancies in 1,800 women, and they looked at cardiac, obstetric, and neonatal complications. And the cardiac complications that they looked at were arrhythmias, heart failure, thromboembolic complications, myocardial infarctions, stroke, as well as endocarditis within the first 6 months. And so what they did was they basically found these independent risk predictors, which was history of arrhythmias, cardiac medications during pregnancy, NYHA class prior to pregnancy, left heart obstruction, and they defined that as a peak gradient greater than 50 millimeters of mercury and a valve area of less than 1 centimeter square, or a valve area of less than 1 centimeter square. Systemic AV valve regurgitation, which was moderate, anything more than moderate. Subpulmonic AV valve regurgitation, again, anything more than moderate. Mechanical valve prosthesis, and cyanotic heart disease, whether it was corrected or uncorrected. And so when you look at that, you basically sort of like tally up those points and kind of see what their estimated percentage rate of cardiovascular complications. And I kind of want to bring your eyes down to this. So imagine if someone had a mechanical valve, they off the bat, again, got 4.2, which put them in a higher risk category of almost 70%. These are the numbers. So if you had a mechanical valve, that was like 70%. And if you had, for like the patient that I showed you early on, someone with like Epstein's, that was probably not captured by CARPREG, but in this scoring system would probably be quoted a risk of 7.5%. So 20 years after, like almost 20 years after the initial CARPREG study, it was felt that we needed a better prediction tool. And once again, the prospectively enrolled cohort was obtained, and the analysis performed to identify these predictors to incorporate into a new scoring system. And so these new predictors were pretty much the same as prior. And what they did was they looked at 1,900 pregnancies. They found 16% cardiac complications. And so the 10 predictors that were identified, 5 of them were general predictors, 4 were lesion specific. And for the first time, they actually incorporated a delivery of care predictor. So if you were a late time presentation, to a to a combined cardiovascular OB MFM clinic, then that put you at increased risk. And so the prior variables were there, and then the other things that were added on were mechanical valve, pulmonary hypertension, coronary artery disease, high risk aortopathy, and then no prior cardiac intervention. So for example, like people who had mitral stenosis that was missed, or severe aortic stenosis, or unpalliated congenital heart disease. And so based on that scoring system, once you tally up the points, if you had greater than 4 points, you were at 40% risk of cardiovascular complications. Again, look at the mechanical valves, like you're already at 3 here. And so if you have mechanical valves with like NYHA class 2 symptoms, or NYHA class 3 symptoms, then that was going to give you a score of 6, which was going to push you over that 40%. And then lastly, I'm going to talk about the modified WHO classification of maternal cardiovascular risk. And this is purely based on anatomy and physiology. It does not take any functional status into account. And for the most part, we pay attention to the 3 and 4. These are the patients that we consider high risk. The ones that are WHO 4, we would recommend them not to get pregnant. Again, that's not something that we have under control. And we usually leave the decision to the patient as long as they're able to make an informed decision. And then knowing what their WHO4 category is, we can actually also estimate based on this scoring system, cardiac event rate, and kind of like what their follow-up probably should be. And so at our UCSF PACT program, what Dr. Agarwal did was that she basically sort of like wanted to see how the risk scores performed in the PACT patients. And so the orange bars over here represent the expected rates for cardiac events, while the blue bars represented the observed rates. And so if you look at the ZAHARA score on the slide, the one described in congenital patients, the observed rates were much lower than expected rates amongst women with higher scores. And what was interesting was that the observed rates were higher than the expected scores in those with lower ZAHARA scores. And it's kind of like unclear as to why we saw this. Was this prominent because we have a coordinated multidisciplinary approach, and so the observed event rate was lower, and were just by virtue of the fact that these were lower risk patients, however, referred to PACT because of other comorbidities, and maybe that's why they had higher observed rates. There's more research that needs to be done on that with our database. The other thing that Dr. Agarwal was able to look at over here was that of the 170 women that was studied, 19% of them had late cardiovascular events, and this was sort of defined more than 6 months, and this was over a median follow-up of 3.8 years. And so when you look at this, and I'll have you draw your eyes towards CARPREG-2 and ZAHARA. So when you look at the CARPREG-2 score, and this is like patients with late cardiovascular events, this is your event rate, and this is years after delivery, and we were able to have at least follow-up for about 10 years, although mean was 3.8. There was the blue line is for CARPREG 0 to 2, and the red was for anything greater than 3. And as you can see over here, that if those patients who had higher CARPREG scores also had much more significant, almost a 50% risk of late cardiovascular events greater than 6 months at about 6 years. And the same was sort of true for ZAHARA. Here in green, ZAHARA scores of greater than 1.5 predicted pretty much like higher event rates as well in our cohort of patients. So the takeaways from the scoring system is that no single score is perfect. ZAHARA is the only one for congenital heart disease. The modified WHO is easy to use, but does not take into account functional status. CARPREG-2 is recent and emphasizes early risk assessment. And what we tend to do in the PACT clinic is we will report scores for basically the all 3 scoring systems, but pretty much summarized based on our own experience and the available resources of the 2 campuses that we have, whether they would fall into a low, moderate, or high risk category. So now moving along to the challenges that we face with management in our patients. And kind of what I thought I would do in this section of the talk is really go through case examples and sort of like walk you through a series of cases where each case highlights a unique aspect of our program and what we face when we take care of these of the patient with high-risk cardiovascular disease. And so it's accurate history and assessment, counseling, it's heterogeneity and recommendations and outcomes, pregnancy when it's contraindicated, applicability of current scoring systems in our patient, ethical considerations, anticoagulation during pregnancy, interventions during pregnancy, multi-campus management, postpartum management, and multidisciplinary teams. So in terms of accurate history and assessment, it's really important to get, for a congenital patient, prior repairs, because in some cases, like you might miss something if not actually evaluated thoroughly in advance. Or, patients who have hypertensive disorders of pregnancy, it's like important to know, did they have preeclampsia? When did they have preeclampsia? And how is that treated? Or even LV dysfunction, like what does it mean when they say they have heart failure? Sometimes they say they have heart failure, but we're not really sure what that meant. Did it mean that they had stress cardiomyopathy? Did they actually have frank heart failure? Or did it have a flavor where it's peripartum in nature? And if it's peripartum in nature, that is a lot more concerning because those patients have more dramatic clinical presentations and phenotypes. And so this lady was actually a woman who underwent, she was a coarctation, was a late repair, who actually had a patch aortoplasty and pretty much was lost to follow-up and had 2 pregnancies, sailed through her pregnancies in her 20s, and then later showed up and she was found to have a 7-centimeter aneurysm. And you can imagine that if this patient had been caught prior to her getting pregnant, she would have been operated upon. This is one particular repair that we always worry about aneurysm formation and dissection at the time of the 3rd trimester and delivery and postpartum. And so getting that history is absolutely important. Next, when we talk about like counseling, risk recurrence, and genetics, they probably go hand to hand. When we counsel people with congenital heart disease, for the most part, we say that congenital heart disease is 1% of the population. However, if a woman has congenital heart disease, the risk of the offspring is about 7% if they're a female, or if it's a man, then we tell them it's 3%. Syndromes, like if someone has a 22q11 mutation, then that's important to know because that's a 50%, that's autosomal dominant. And so that would be like a 50% risk recurrence in the offspring, as well as aortopathies. Those could be significant too if someone has Marfan's and has an FBN1 mutation, or vascular EDS with a COL3A1 mutation. Then of course, cardiomyopathies, it's important to know if someone does have a cardiomyopathy, that we're able to send them to genetics, or if they have a family history. Sometimes we'll see patients who have family histories, their mom, sister, aunt, all have heart failure. All have heart failure, either during pregnancies, postpartum, or later on in life. And those patients you absolutely want to capture and be able to get them to genetics so we can modify our counseling, as well as probably be a lot more vigilant in terms of management and getting them on medications. And so this is an interesting patient that we saw in PACT clinic. She's a 36-year-old, has a strong family history of sudden death. Mother had a dissection at age 69. And so she was appropriately referred by the primary cardiologist to genetics prior to her coming and seeing us in PACT. And she was found to have this likely pathogenic NYLK mutation on testing, but she had an echo and an MRA that was normal. And so it was felt, oh, well, her aortic dimensions are normal. And so she should be fine during pregnancy. This is a table that sort of like, was published along with the ESC guidelines. And they talk about like, different kinds of aortopathies and what their risks are. For the most part, bicuspid valves tend to be sort of like benign, unless of course the aorta measures greater than 5 centimeters. Marfan's, we probably have a lot more guidelines. We have clear kind of set guidelines in terms of when we need to intervene. But the wildcards are usually Louis Dietz, vascular EDS, ACTA2 mutations. I mean, those patients with these mutations have a more unpredictable course. And kind of going back to this patient that we saw in clinic, we did a little bit of digging around, again, I'm not a geneticist, but kind of like looking at the genetics notes, this particular mutation, there's actually data that shows that, those who have missense mutation versus a null mutation actually have a higher incidence of dissecting at normal dimensions or minimally increased dimensions. And so now my approach changes a little bit. It's not that we're going to necessarily do anything different, but I'm probably going to want her to come back and follow her aorta a little bit more closely, as well as counsel her that if she has chest pain, that she needs to go to the ER and get herself evaluated and not think that this is GERD or musculoskeletal pain. Also, sort of like on the lines of counseling, we actually use aspirin a lot in recent years to prevent preterm and term preeclampsia. And this is recommendations by the USPS task force, where for the most part, it was initially used in those patients who had a prior history of preeclampsia, and then that was broadened to those with any kind of hypertensive disorders of pregnancy. And now we've actually broadened it even further to patients who are nulliparous, who are obese, who have a family history of preeclampsia, to Black people. And it clearly says over here, this is for social rather than biological factors, for low income, for someone who's greater than 35. So our previous patient, who's 36, would be counseled to go on aspirin. And the aspirin really should be initiated around 12 weeks. And this is the thing, and the thinking is that, the placental development occurs in 2 stages, and one's like around 12 to 14 weeks and another 17 to 19 weeks. And so you want to get that aspirin in sooner, because there's no point starting it at 25 weeks. You've lost it by then. Next, going on to the next challenge is heterogeneity and recommendations. And I wanted to show you 2 cases here, sort of like contrasting how we take care and counsel Fontan patients. This is a Fontan patient who is 20 years old, double inlet left ventricle. You can see the LV over here. For the most part, well-functioning, who was seen by an outside cardiologist and was actually pregnant twice and was told to terminate twice, even though she really didn't want to. She felt under pressure to terminate based on their recommendations. And then she comes here to PACT and sees the PACT physicians, who basically said, well, she's a well-functioning Fontan and would fall in the modified WHO3 category. And so there is risk, it's not contraindicated. And she decided to go ahead, get pregnant and actually delivered with no complications. As opposed to another patient that we had in our clinic who ended up going actually into med school, but she's the 31-year-old tricuspid atresia who had a Bjork type Fontan, who was actually functionally doing very well, was a beautiful repair, that was mentioned by the prior pediatric cardiologist and the surgeon, asymptomatic. And she got pregnant and then ruptured her membranes at 21 weeks and was hospitalized for the entire duration, finally delivering by C-section at 31 weeks. She did well postpartum, but this was obstetric and she did have obstetric and fetal complications. And so in terms of like heterogeneity and recommendations, both women started off with the same functional status. Both women had Fontans. Both women had preserved single ventricular function, yet the recommendations for pregnancy differed and outcomes, frankly, differed too as well. And it becomes really hard to counsel patients like this, given just how complex they are, and that different physicians and different people have sort of like these varied perceptions of what their risks are in terms of pregnancy and delivery. And so when you're looking at, so I sort of like was interested in this and kind of like looked at the outcomes. We actually don't know what the long-term outcomes are for Fontans who undergo pregnancy. And a lot of it is because the Fontan palliation came out only in 1977. And so this is all pretty new to us. And so this is a meta-analysis that was done. And for the most part, the outcomes are actually not that terrible. There's about 8% risk of arrhythmias and about 3% risk of heart failure and less than 2% risk of systemic embolism. But for the most part, they actually did pretty okay. This was a meta-analysis which looked at 212 patients. There's a high incidence of miscarriage in these patients with Fontans, and so only about 94 of them were viable. And the biggest issues with these patients are the fact that A third of them tend to be on anticoagulation based on recommendations or prior history of arrhythmias or single ventricle dysfunction. And hemorrhagic events tend to be actually quite high in this group, more so probably than thromboembolic events. And that probably puts them at a higher risk, but there was actually no one, I think, who died in this cohort. And so our recommendations have changed, and have probably gotten a lot more liberal when it comes to the front-end palliation. And so when we talk about, I guess, moving a little bit now from recommendations to pursue pregnancy in terms of like outcomes, again, this sort of like differs. This is looking at systemic right ventricles. And so these are both transposition patients. On the left-hand side panel, this is a patient with heterotaxy, with situs inversus, total enormous pulmonary venous return that was repaired, congenitally corrected transposition. So had a systemic RV with severe TR, and this is systemic AV valve regurgitation. Who pretty much had also normal, kind of like normal function. And then you have a detransposition atrial switch, with a mustard who had sub-PS that actually was protective, who also had preserved systemic ventricular function. And yet this woman sailed through 3 pregnancies and deliveries. And this lady, unfortunately, succumbed to heart failure within her first week postpartum and was admitted to an outside hospital. And while she was being intubated for pulmonary edema, ended up coding and passing away. So how about pregnancy when it's contraindicated? Again, I'm going to contrast 2 patients for you. So these are patients with pulmonary arterial hypertension. The first case is a 24-year-old who actually went through pregnancy and delivered, but postpartum developed heart failure. And on evaluation, ended up being diagnosed with a sinus venosus ASD, as well as severe pulmonary arterial hypertension, who needed to be started on IV prostacyclins. She, after being followed, went through a treat to close approach. Once her PA pressures came down nicely with therapy, ended up with surgical repair and a residual 3 millimeter fenestration, did very well. PA pressures came down. After that, she came off her IV prostacyclins and was maintained only on sildenafil, and then decided she wanted to get pregnant again. At that point, with excellent hemodynamics, we went ahead and told her that she could, and she successfully just delivered a second healthy child. And this contrasts to another patient that we saw, who is a 33-year-old, who's a G8P7, who had methamphetamine-induced pulmonary arterial hypertension, who was started on IV prostacyclins. And while she was told that we would not recommend pregnancy, given that, one, she's already got 7 children and she has PAH, and we do quote a mortality risk of about 30%, she declined termination. And unfortunately, when she did go and deliver, she was delivered by a C-section. And as soon as the baby came out, she actually coded and passed away. And so again, we sort of like when you look at outcomes, this is from the PACT registry. Outcomes are associated to how high your RV systolic pressure is. So the higher it is, which is the red bar over here, the worse your mortality is. The higher the mortality, the increased incidence in cardiac events in terms of heart failure, as well as fetal complications like small birth weight babies. And when you look at pulmonary hypertension across the board, the different kinds of pulmonary hypertension, for the most part, this is where this comes from, this 30% mortality risk. Blue is the idiopathic pulmonary arterial hypertension, and that is really high. And so sometimes we'll even say 30 to 50%, but this is a very, very concerning cohort and absolutely contraindicated in terms of counseling. So when we talk about applicability of scoring systems, applicability of scoring systems, kind of going back to the first case, the patient with the Epstein's anomaly and severe TR. Well, she sort of when you look at the scoring system, where would she fall? She would fall into this category, which really isn't an Epstein's category. It says native or tissue valve disease. That's not considered WHO-1 or not considered, who for, like your left-sided obstructive lesions. And so, well, how applicable is that to someone with Epstein's? And do you need to look at other things further? The ESC guidelines recommended, especially for Epstein's, they managed to sneak this in, saying that if someone had Epstein's poor functional status or less than 85%, then pregnancy would be contraindicated. But in my previous patient, she was asymptomatic, and so we told her to go ahead. Looking at ethical considerations, these are two transplant patients that I ended up caring for. One was a 27-year-old dilated cardiomyopathy who was transplanted and then retransplanted, who actually suffered rejection immediately after. And so she hadn't been stable with her graft for 2 years and was 6 weeks pregnant. And at that point, based on the fact that she had just been treated, and given pretty much like everything that you could think of to get her through the rejection processes, we basically recommended that she terminate her pregnancy. And this contrasts to another lady who I saw, who was 35 years old, also transplanted, but she was transplanted at age 17, had a successful pregnancy several years later, that was 10 years ago, and now pregnant again. So now she's about like 17, 18 years out from her initial transplant, and she came in for routine left heart cath and was found to be pregnant, and she decided that she wanted to pursue a pregnancy. But 18 years after initial transplant, what are the considerations there in terms of counseling her regarding pursuing pregnancy? And that's something to think about. Again, we really rely on our transplant colleagues as well to help us make that decision. But I think these are just both very difficult cases, in terms of what does that mean? And a lot of it is because we just don't know what the long-term outcomes are for these patients. And this is a meta-analysis that came out of Canada, Heather Ross's group. And they found that for the most part, mortality during pregnancy was 0.5%, but during follow-up was a lot higher at 15.4%. These, of course, were both lung and heart transplant patients. However, we do have to keep that in mind, especially with this cohort. We may be able to get you through pregnancy, but what does that mean going forward long term when you've been transplanted? How do you make that decision? I'm just going to quickly go through the slides. Anticoagulation during pregnancy. We had one lady who had rheumatic mitral and aortic disease who basically had pretty acceptable gradients, had 2 miscarriages. Anticoagulation during pregnancy, as I showed you with the prior scoring systems, that puts you in a really, really, really high risk. And so, you kind of really do need to look at, what the outcomes are. And sort of this was a really nice meta-analysis where, they showed that vitamin K antagonists were associated with lower risk adverse maternal outcomes, whereas the use of low molecular weight heparin throughout pregnancy was associated with, lower risk of adverse fetal outcomes. However, the fetal risk was similar, with women taking less than 5 milligrams daily versus low molecular weight heparin. And sort of there's this sort of table that we follow, bringing patients in, when do we switch them from Coumadin to heparin, or again, won't go too deep into this. At UCSF, for the most part, we prefer just switching them to low molecular weight heparin and doing TID dosing, as well as really closely monitoring their factor Xa levels. But TID dosing is something that we do, which is opposed to BID, which is what was recommended on this. When we think about doing interventions during pregnancy, it's we really do it, during the second trimester. This is a patient who had a coarctation of the aorta that we had to, that was pretty tight, that we had to intervene during the second trimester. And for the most part, that's when you do it. I mean, or you do it after pregnancy, but if it's emergent, then you probably just should do it anyway. And that's exactly what happened with this patient. This is a lady who came in 20 years old with incessant atrial tachycardia, heart rates of, in the 180s, had ventricular dysfunction, MR, needed to get her out. She was ablated at Mission Bay by pediatric EP. And they found an area that was sort of the area between the left atrial appendage and the left upper pulmonary vein. And this was during 30 weeks pregnancy, and she actually did very well with the improvement and recovery of her function and trace MR. In terms of multi-campus management, this is a patient with heart failure. She kind of it was peripartum cardiomyopathy versus methamphetamine. cardiomyopathy. She had aborted sudden death after DNC, had an ICD placed. She was hospitalized 26 weeks and, with heart failure. And so we made the decision to transfer to Parnassus. And so why did we make the decision to transfer to Parnassus? And the worry really is, management of heart failure. If they're stable, you can get them away, you can get away with just doing medications. But if they're in cardiogenic shock, you need to go probably for, kind of get them on pressors, diurese them, PA catheter if needed, and sometimes even urgent delivery via C-section in these cases, and then hope that their function recovers. And if it doesn't recover, then you think about transplant if they're still unstable, or if they've moved over to not being stable, you get them on medications and really try to titrate up their GDMT. When you look at the incidence of peripartum cardiomyopathy over time, this has increased in recent years. And, you see a lot of these patients, coming in with heart failure in that first couple of months after delivery. And so if you suspect, heart LV dysfunction, peripartum cardiomyopathy, any kind of, issues with the subset of patients, that first 3 months is vital to kind of like monitor them. And so in terms of like why we transfer that patient to Parnassus was because in someone who had, peripartum cardiomyopathy, possible peripartum cardiomyopathy, her event rate in a subsequent pregnancy is 20% mortality. That is extremely, extremely high. And so the ability to have heart failure transplant on board, the ability to be able to offer her advanced therapies is absolutely needed. This is probably the only condition where we can say, there's people have studied non-pregnant versus pregnant patients, and have noted that, if the patients who got pregnant, with LV dysfunction had sort of like worse event rates and worse cardiac outcomes as compared to those patients who never did get pregnant. This is something that we cannot really apply to the other types of acquired or congenital heart disease. But something that we do notice, and that has at least been studied for in this sort of like group of patients. I think this last couple of slides, this is postpartum management. This is a lady who was 29, she was a Fontan, a severe MR. And she came in like, a couple of weeks postpartum with extensive DVTs and actually ended up needing bilateral ECOS catheters in her popliteal veins to be able to lyse those clots. And, it's like, you really have to think about like, in high-risk patients, continuing anticoagulation postpartum. I mean, we sometimes do that during pregnancy, second and third trimester, but it's important to continue it at least for 6 weeks postpartum if they're deemed to be high risk for VTE. And then this is the last case that I wanted to show you, which is really like sort of like a multidisciplinary management in a really, really, complicated, high risk, WHO contraindicated type patient. This is a 33-year-old with chronic thromboembolic pulmonary hypertension who had endarterectomy in San Diego, who had RV pressures that were 2/3 systemic and a PVR of 8, and she wanted to get pregnant and she came in for counseling, and, she was recommended that pregnancy was not advised, but wanted to go ahead anyway. So she was started on an IV prostacyclin and successfully delivered. Luckily for her, she had preserved RV function, but the efforts that went into this, in terms of like multidisciplinary planning and all the people that needed to be involved to look at timing, mode, neuroaxial anesthesia, anticoagulation management, hemodynamics, ICU, nursing, do you give diuretics or IVF postpartum? This was really, really complicated and really required a multidisciplinary approach and multidisciplinary planning. And we actually decided to deliver her at Mission Bay, and thanks to Amy McCammon, who's the pediatric medical director in the ICU, these were all the people that were invited. We had like 40 people on this call trying to manage a very complex patient for which, remember I said this was a 30% mortality in this cohort. And she actually did very, very well. And that's probably attributed to the fact that this was a multidisciplinary team with many people on board. This was the email that was sent out, literally highlighting each and every single step, who would need to be contacted, and what would be needed to be done for this patient. And then lastly, post-delivery follow-up and late cardiovascular risk, that is important. Again, this is out of the scope of today's talk. And, kind of like going back to our UCSF PACT program, This is unique. We've managed about 600 women, 45% of them have had a congenital heart disease, 12% cardiomyopathy. We have probably one of the lowest C-section rates in the country. Our mortality is less than 0.1%. And this is my second to last slide. Wanted to just highlight a quick miracle patient who had a miraculous delivery. This is a woman who's 24 years old, who had a double outer right ventricle, upstairs, downstairs configuration with crisscross AV valves. Again, you don't have to worry about that. All you need to know is that she had a huge VSD, basically has blue blood and red blood that enters the heart. Yet when it comes out, and these are her aortic valve and pulmonary valve, the blue blood goes out through the PA and the red blood goes out through the aorta. Oops, I think this got. The blue blood goes out through the PA and the red blood goes to the aorta, and she did absolutely fine. Like, she should never have been alive. She was alive. Her SATs are 97%. She got pregnant. She delivered with no complications. And that pretty much was one of our miracle stories. And so I think that was pretty much the last slide. So thank you again for inviting me. I hope this sort of like gave the division kind of like an overview as to what we do in the PACT program and the complexity of patients that we see and how we manage them. Happy to take any questions.
Thank you so much. That was wonderful. It was really interesting to hear all of those cases. We are almost out of time, but I wanted to make sure and see if anyone has any questions that we can ask quickly. I was personally just curious if you happen to know if there are any ongoing trials to develop risk scores, kind of like the ZAHARA and the CARPREG, in a more diverse patient population. ZAHARA, you mentioned, was the only one that looks at congenital heart disease patients, but I noticed that it is based in Europe. So I wasn't sure whether, genetically the rates of congenital heart disease are different there than here.
No, I don't think the rates are different in congenital heart disease. I think pretty much it's relatively the same across the board. I mean, in terms of using risk stratification tools and scoring systems, I think in a diverse population, I think that's always, I mean, that absolutely would be important and very helpful, especially if you're going to be attributing a lot of this risk scoring systems, because it also depends on sort of like, kind of like what systems do you already have in place to take care of these patients. What we have here may be, different elsewhere. Like, take, for example, like, a place like here, we have like 2 different campuses, and I know that things across the country, like, there's some places where OB is separate from cardiology, and then there's some places where pediatrics is separate from OB. So all that has to be taken into consideration, when you're delivering these patients with complex disease, and also worrying about like fetal outcomes too at the same time.
Thank you. If no one else has any other questions, Dr. Singh posted an article.
Oh. Hey, Aarthi, thanks for a nice presentation. I was just sending an article that Rob Hayward, one of my former mentees, did, where we quantified these risks specifically in women with and without CHD. And bottom line is, like, these are very rare outcomes, but not surprisingly associated with higher risk. And many of these outcomes, I think you highlighted atrial arrhythmias, heart failure, readmissions, but those data might be helpful.
Yes, I've seen that data. I think you did that with Foster, right?
Yeah, Elise was helpful with that too.
Yeah. Thank you for that. Thanks for sharing.
All right. Well, thank you everyone for joining, and thank you again, Aarthi. We'll see you guys next week with Dr. Richard